That's wonderful. Thank you so much for the invitation and good afternoon, everyone. And very pleased to be joining you and speaking today on the use of artificial intelligence to optimize ovarian stimulation. So as we're all familiar, the number of eggs is obviously very important for optimizing success rates during IVF treatment. So here we can see that the greater the number of oocytes, the better the live birth rate, especially at lower oocyte numbers. Thus said, there is still room for improvement. So this is data from the UK in more than 500,000 cycles. 7% of cycles, there was no eggs retrieved, and 12% of cycles, no embryos. So there's still room to optimize and improve our treatment. And as we know, IVF is a complex, multi-step process. However, potentially artificial intelligence is going to have a role in most of these processes. So I'm sure, understand in your conference you've heard already about embryo selection and so on. Today I'm going to be mostly focusing on ovarian stimulation and triggering. So, as we know, during IVF treatment, follicle stimulating hormone induces the growth of multiple ovarian follicles. And then we usually decide when to administer to the trigger of oocyte maturation using the lead follicles, so the largest follicles, usually when two or three of the largest follicles reach 17 or 18 millimeters, depending on the unit, we then say it's time for the trigger to be given and institute oocyte maturation. And I think that works quite well if all of the eggs, all of the follicles were to grow together, as in this example. However, if they were disparate from the remainder of the follicles, if you had two or three much larger follicles, I think intuitively many of us would ignore the rule of triggering and wait a bit longer for some of those smaller follicles to catch up. And why do we do this? Because I think inherently we know that follicle size is going to determine the ability to respond to the trigger of oocyte maturation. So this is some data from Shapiro looking at the size of follicles on the day of oocyte retrieval. And you can see that the sort of larger follicles, 19 to 21, are more likely to yield a mature oocyte than smaller follicles. And there might even be a little dip at even larger follicles beyond that. So clearly, oocyte, so follicle size is important. But why did we get interested in this area? So I do a lot of research on kisspeptin. So kisspeptin is a hormone that stimulates the hypothalamus and stimulates the rest of the reproductive axis. And we got interested in the use of kisspeptin during IVF treatment. And that's because this is some animal data showing that kisspeptin is probably the natural instigator of ovulation physiologically. So this is some animal data showing that if you infuse vehicle into the hypothalamus, you get the normal LH surge. But if you block kisspeptin signaling, that is no longer the case. And so what that means is that you need kisspeptin for physiological ovulation. And actually giving kisspeptin could be a novel trigger of oocyte maturation. So as we know, HCG is the commonest trigger acting directly in the ovaries. GnRH agonist will act in the pituitary gland, and kisspeptin will act a level up in the hypothalamus to stimulate endogenous GnRH and thus the rest of the axis. And in 2014, we did this study where we used kisspeptin to induce oocyte maturation as a novel trigger of oocyte maturation. And you can see that the amplitude of the LH response, about 45, 50 international units, is remarkably similar to the amplitude of the natural LH surge. So again, speaking to this concept that kisspeptin is the sort of natural instigator of ovulation. And one of the benefits of using kisspeptin is that the rates of OHSS were much reduced. So this is in high responders. We can see that both signs, so ovarian volume, ascitic volume, as well as symptoms, nausea, vomiting, abdominal pain, were much reduced when we use kisspeptin in the green as opposed to HCG in the red. And whilst that's predominantly due to the different durations of action, obviously HCG has a very long duration of action. It could also be partly because of a direct action in the ovary. So there are kisspeptin receptors in the ovary, and kisspeptin also reduces vascular endothelial growth factor with a direct action, potentially contributing to that effect. However, obviously, the duration of the LH surge that we got with kisspeptin is shorter than the natural LH surge. So you can see the natural LH surge is triphasic and lasts up to 48 hours. The amplitude of 56 is about right. However, it's a longer duration. And so, therefore, we've also looked into the use of this slightly longer acting kisspeptin receptor agonist. And this is probably the closest profile to what you see to the natural LH surge. So, you can see both the amplitude and the duration very nicely simulates the natural LH surge. But anyway, so obviously we're doing research on a novel trigger. One of the things obviously we'll need to do is assess the efficacy of that trigger. And in order to do that, we need to know how many eggs are we expecting. And as we've mentioned already, if the follicles are too large, they may not give us an egg. They may be post-mature. And if they're too small, they also may not give us an egg. So there's this optimal size in the middle where we can expect an egg if appropriate triggering is provided. So, for example, if this was the optimal size and there were 9 follicles, and then we had 9 eggs, then we would be happy that the trigger has done its job. It's going to have a good response to the trigger. However, if we only get 3 eggs, then the trigger has not done its job and we've had a poor response to the trigger. Conversely, if there's only 3 follicles, we wouldn't expect more than 3 eggs. And if we do get 3 eggs, the trigger has actually done its job. Even though there aren't many eggs to achieve, it's not a problem with the trigger. Sometimes we don't always separate these two issues properly and just look at poor response and not say why the poor response has occurred. So this is one of the reasons why we wanted to know which of the follicles that you would expect to give you an egg if appropriate triggering is provided. It would enable us to quantify the efficacy of triggering. And so therefore, obviously it's quite a complex mathematical problem. You've got lots of follicles, then lots of eggs. How do you relate the two? We actually collaborated with Professor Thomas Kelsey at the University of St Andrews. I think we published this paper in 2018, and I think it's an important question because obviously many people wanted to read it. It's had 1.3 million views. And essentially, we used artificial intelligence to try and decipher it. So, just as a sort of background to artificial intelligence is a sort of broad overall term. And within that is machine learning, where you need computing to be able to undertake the processes. And then it can be further subcategorized in terms of supervised and unsupervised techniques. So supervised is where you tell the program the outcome of interest, as opposed to unsupervised, where you're sort of doing cluster analysis or things like that. And then I suppose the other main differentiation is that explainable AI enables you to find out how it's making its predictions, as opposed to black box techniques, so things like neural network, where it gives you a prediction and it tells you how well it works, but you don't know how it's making that prediction. You don't know how it got to that answer. So for this problem, we actually used what's called a random forest. So the way that works is it basically builds a decision tree. So for each follicle, to try and predict the number of eggs, you put in all of the different follicle size, it will do a decision tree, and that will be one decision tree. And then it replicates this process over and over and over. In fact, sort of thousands and thousands, usually 10,000 plus decision trees. And then that becomes, you average those decision trees and that becomes a forest. So that's called a random forest technique. And that we did in a few years ago with about 500 cycles from a randomized controlled trial. But we've actually just updated this within the last year or so using data from 11 clinics in the UK and Poland with almost 20,000 cycles. We used just the first cycle, selected patients where they had at least 3 follicles. And we used what's called a leave one clinic out strategy to cross-validate the model. So I won't go into this in too much detail, but essentially in the past, if you had a large data set, you would maybe train your model and say 3/4 of it and then validate on 1/4 of it. Increasingly, it's recommended to use the entire data set, split it in different sections, and then repeat, leaving one section out at a time. So that's making full use of the data and then still has that robustness of leaving one section out. Okay, so coming on to the results. So these were the results of the random forest. So what we have is on the x-axis, different follicle sizes, and then on the y-axis, the normalized importance. So this is how important follicles of that size were to the outcome. So in this case, it's to the prediction of the number of oocytes, so the number of eggs. So you can see that follicles between 12 and 20 were the most important for predicting the number of oocytes. You can see it's not that follicles outside this range don't help at all. They do contribute, but these are the ones that contribute the most. And then if we look at just mature oocytes, follicles of 13 to 18 were the ones that contributed the most. And then if we consider just high quality blastocysts, slightly narrower range at 15 to 18 were the most contributory follicles. So this is all on the day of trigger as opposed to the day of collection. We also tried to validate these predictions. So the ones on from the random forest were with the permutation importance analysis. There's another form of AI called SHAP analysis, and essentially it showed very similar results. So again, 13 to 18 corresponding very well to the random forest analysis. So not everybody had a scan on the day of trigger. So in our unit, if they're triggering on the Saturday, for example, they won't necessarily have a scan on the Saturday if they were ready on the Friday. And so we had a look at do the size profiles change by the day of trigger. So on the day of trigger, predicting mature sites was 13 to 18. If we go day -1, then the follicle sizes shift 12 to 17, and that's obviously what you'd expect in keeping with the anticipated growth rate. And then if you go day -2, it shifts again to 10 to 15 millimeters. So again, this is quite reassuring. It suggests that the program is giving us appropriate results. We also split the data by whether they'd had a long protocol or as opposed to the junior H antagonist short protocol. So you can see on the left with the long protocol in red, you can see follicles 14 to 20 were the most contributory, and the slightly bigger spread on the right with the antagonist protocol, so similar 12 to 19 millimeters. We also had a look at age. Was there any different follicle sizes in people who are younger versus older? So in the younger group, 13 to 18, again, much like everyone else. In the older group, slightly more at the slightly upper end. If anything, we would have anticipated maybe needing to trigger earlier. So quite interesting that slightly larger follicles, if anything, seem to be most contributory. We then assessed whether the standard rule for introducing the trigger, so either 2 or 3 follicles more than 17 or 18, compares to whether we try and maximize the number of follicles within this optimal range that we've identified. So on the left is the standard rules, so either 17 or 18 millimeters. And then on the right is what happens if you try and increase the proportion of follicles within this optimal size range. So 13 to 18 in blue, 15 to 18 in red. And you can see that you can hugely increase the proportion of eggs that you will get out. So again, this is a hint towards perhaps we should be considering all of the follicles rather than just the lead follicles when making the decision regarding triggering. We also assessed, does this impact on live birth? So this is with only patients with fresh embryo transfer, almost 10,000 patients. And essentially, we looked at the proportion of follicles that were in this optimal size range on the day of trigger. And as you can see, as that proportion increases, there's a gradual increase in the live birth. So for each 10% increase in that proportion, the odds of live birth increases about 3%. Conversely, we also had a look at the mean follicle size, so the average follicle size, and essentially patients with larger follicles, if anything, had a tendency towards lower live birth rates. So why might that be? Obviously, if you wait for longer, then the number of larger follicles, so more than 18 millimeters, which is outside our optimal range, is increased. And the more of those follicles you have, the more progesterone is going to be elevated prematurely. And as we know, this could advance the endometrium and make it out of sync with the time of embryo transfer. And whilst that might not have a huge impact on the mature oocyte yield, it does have an impact on the live birth rate, as we know. So the greater the serum progesterone on the day of trigger, the lower the live birth rate in blue. Okay, so this is one of the reasons that we wanted to identify the follicles that are most likely to give you eggs, is it enables us to quantify oocyte maturation. So we can express the proportion of mature oocytes as a ratio to the number of follicles on the day of trigger that should give you an egg. And what's often used in the literature now to assess triggering, the efficacy of triggering, is the oocyte maturation rate, which is the proportion of eggs that are mature. But the problem with that is that if triggering is insufficient, you get fewer eggs as well as less mature eggs. So the proportion doesn't change as much as you'd like, and you can see this is a non-significant difference even with the HCG level. However, if you express the number of mature oocytes as a proportion of the follicles that should give you, you do see then a relationship with the endocrine parameters following triggering. So the HCG level after HCG and the the LH level after GnRH agonist. You start to be able to relate the triggering endocrinology to the actual efficacy of the trigger. Okay, so that's one reason, is to identify the efficacy of the trigger. Another reason is that it enables us to have a target for our follicular growth. We know what size of follicles we're aiming for. We want to maximize the follicles within that range. So we did this paper in 2019. So as you know, FSH should be is obviously related to body weight. So if you do the FSH dose divided by body weight, it correlates very well to the serum FSH level in the blood. And then you can basically use that weight-based dose to predict the median follicle size after 5 days of recombinant FSH. And what's really interesting is that median follicle size, once the follicles start growing, they seem to grow very predictably. So this is the median follicle size on day 5 versus the median follicle size on day 7. And you can see there's a very nice correlation. And similarly, day 7 correlates very well with day 9. So once they start growing, it becomes a bit more predictable. But what happens if you start too low a dose than you should have done? So how important is getting the initial dose correct? So let's say we started a suboptimal dose. Obviously, there are different sensitivities within the antral follicles, and you might still get some follicles that start to grow. They might then have a monitoring scan on day 5 of stimulation, and the clinician might well increase the dose as there's been a suboptimal response. And that's going to induce the growth of another group of follicles. So essentially what's going to happen is you're going to increase the spread of the size of follicles by the time of trigger. And as I've said, you want to try and get all of the follicles really to grow together and all be within that optimal range so that the trigger has the best chance of working. So this is showing that if you've needed to increase the dose, so on the x-axis, on the right is those that needed at least a 5% increase in the dose. You can see that there's a smaller proportion of the follicles that are within the optimal range on the day of trigger. And this then translates into fewer mature eggs that are then collected. So important to try and get that optimal, that initial dose right and try and get the follicles to grow together. So we've also, this is some unpublished work that we've been looking at recently, where we try and model the growth of follicles during the cycle. So I showed you some data already on changes in the mean follicle size. So what they've done for that data is they've averaged the size of follicles on each day, and then they've looked at the differences by the day. But what we did in this paper was we looked at the growth of individual follicles. So for each follicular gram, we ranked the follicles and basically looked at the difference between the first follicle in each one, the second follicle on each one, etc. So what you can do is actually work out on an individual follicle basis what is the average growth rate. And the average growth rate was about 1.35. I think based on the mean follicle growth rates in the literature, it was slightly higher at sort of 1.7, but that was on the mean follicle size rather than individual size. And what we then did was looked whether this individual follicle growth rate changes with the number of days of stimulation. So it's relatively stable. There's a slight decrease in the follicle growth rate with the days of stimulation. And we also looked at whether the size of the follicles determined the growth rate. So larger follicles had a slightly higher follicle growth rate than smaller follicles, so on an individual follicle basis. But generally, it was really quite predictable. And what that means is that even just using the follicular gram on the first day, we're able to predict the follicular gram on the final day, so on the day of trigger. And within a couple of millimeters, you've got sort of 80% accuracy just from the very first scan in terms of predicting the final day of trigger. So essentially, the knowledge of the optimal follicle size is obviously clinically very useful, and it enables us to decide triggering by considering all of the follicles rather than just the lead follicle. And we've shown that being able to do that can optimize the oocyte yield and optimize the live birth rate. It also provides a target for ovarian stimulation and enables us to quantify the efficacy of inducing oocyte maturation with the trigger. And clearly, AI methodologies are going to have a huge impact in terms of both assessment, monitoring, and decision making within IVF treatment. This is our team at Imperial. Thank you very much for listening. Thank you very much to our funders, and look forward to any questions.